Hi, I'm Lori. Welcome and thanks for joining us for today's HIStalk webinar entitled Meaningful Use Stage 2, Veterans Speak Out, Implementing Direct Secure Messaging for Success. It's sponsored by DataMotion. Attendee phone lines have been muted to prevent background noise. You can go to GoToWebinar's questions box in the console to submit questions to our panel at any time. The panel will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a link to the recording as well as a PDF version of the PowerPoint presentation. Our webinar will begin with Andy Nieto, who is the Health IT Strategist at DataMotion. Andy will present an introduction to direct secure messaging. Following him, Mr. HIStalk will moderate a discussion with the following panelists: Darby Baroker, Executive Director, Health Information Exchange Development and Information Services at Stewart Healthcare; Ann Laura, CIO of Union Hospital of Cecil County, Maryland; Matt Osmansky, Senior Application Analyst at Stewart Healthcare; and Bill Wynn, PhD of Navin Hafty and Associates. With that, I'll turn it over to you, Andy.
Thanks so much, Lori. I appreciate it. Our goal today is to give you an overview of what direct secure messaging is and how it affects our decisions around meaningful use too, and maybe give you a glimpse into where direct secure messaging is going. After that, I'll pass it over to Mr. HIStalk, and we'll go from there. So we're going to go through what direct is, really. We're going to dive into the ecosystem a little bit and how it affects your decisions around meaningful use and decisions around your community program and community connectivity programs. We're going to talk a little bit about the challenges that we see in the industry. We're going to talk a little bit about the successes we see in the industry. To start off, let's talk directly about meaningful use. As you're very aware, hospitals have 16 core measures they have to meet. There are actually 3 that can be met with direct secure messaging. You're probably familiar with number 12. This is the transition of care component. Number 6 is the patient ability to view, download, and transmit information. We're also seeing a number of areas where syndromic surveillance data can be transmitted to local health departments and registries. When I look at the main objectives, we see the ability to areas where providing structured lab results to the ambulatory providers is available via direct secure messaging. Stopping for a moment to look at the eligible, they actually have one more core measure than the hospitals, and they still have the 3 core measure opportunities using direct. There's a lot of confusion in the market right now and in the industry, especially around this idea of encrypted email, regular email, and direct secure messaging, where they're similar and where they're different. So let's start talking about it from that perspective. All 3 use a standard messaging format. All 3 are using some kind of MIME-compliant messaging. All 3 use the internet for delivery. This is where they become a little bit different. Encrypted email and direct secure messaging both encrypt the message, but encrypted email is a proprietary encryption based upon whichever vendor is providing the encrypted email, whereas direct secure messaging uses a standardized encryption based upon a public key infrastructure. Direct secure messaging also meets the needs for identity validation. This is part of our privacy rule compliance. When the direct secure messaging is created, each of the individuals participating has a digital certificate issued to them. That digital certificate requires that they've been identity validated. We also see an end-to-end trust and liability. We get this both to meet the breach notification rules, but we get this from our environment of HISPs, or Health Information Service Providers, where all of the participants are connected in some way and all agree to operate at a certain level of certain standards, complying with all of the rules and regulations. So we can see this workflow from the sender via whatever mechanism they're using to send, through a HISP, or Health Information Service Provider, which exchanges the identity validation certificates and the encryption information with the receiving HISP before delivering the message to the recipient. Now, I told you we were going to talk a little bit about the ecosystem. The ecosystem as viewed by the Office of the National Coordinator for IT, is this: a group of HISTs that have a relationship that facilitate from one side, as we see an EHR on the left-hand side, to the right-hand side, which might be a registry, personal health record, an HIE, or other provider. Now, there are a number of challenges in the industry, and I want to talk about some of those challenges. The first is, who has an address? Many hospitals are getting up to speed with direct secure messaging, but fewer ambulatory providers are. It's a lot like having the first fax machine. You have a fax machine and you want to send someone a fax, but you don't have anybody who is receiving. This is a very large challenge that's being exacerbated by the costs of rolling out meaningful use 2 certified EHRs at the ambulatory area. Rural rates of adoption are much lower than urban rates of adoption, due in part to the changes in the workflow, the costs associated, and the interest. Another thing I find fascinating is that providers seem to have a lower awareness of direct secure messaging than their CFO counterparts. The CFO counterparts and the financial counterparts are interested in the meaningful use dollars, so they're aware of the needs. I spoke to a provider just a couple of days ago, and I said, "Do you have a direct address?" And he said, "Yeah, it's drjones@gmail.com. I said, no, that's an email address. I'm speaking about direct. And he really didn't know what I was speaking about. When we look at all these things, part of the problem around it is getting field deployment of the certified version of the EHR where direct secure messaging can be part of the environment. As a result, ambulatory providers are less likely to have direct capability. Now, those are some of the challenges. Let's look at some of the successes. 44 states have now adopted direct secure messaging as a standard healthcare communication protocol in their environments. The levels of deployment vary from state to state, but it's nice to know that a number of states, like Ohio, have fully implemented direct as a component of their state health departments. There's a Nebraska, Kansas, Missouri pilot program that's been going now for about 18 months, and it's having great success at communicating not just transition of care events, but communicating immunization registries and syndromic surveillance. Some numbers. I was asked to provide some numbers. As of August 1st, 1,898 eligible professionals have attested for MU2, and 78 hospitals have. One of the questions I regularly get is, where do I get direct? How do I get this? Well, a HISP, or Health Information Service Provider, provides direct secure messaging. When you're looking at a HISP and you're making a decision, which HISP do I want to use, there are some questions I would ask. The first is, are they accredited? Under the Direct Trust, which is somewhat the de facto governing body of direct secure messaging, they've partnered with ENAC to provide a certification, a DTAAP certification and accreditation. Have they demonstrated interoperability? There is a monthly interoperability work group that demonstrates successful integration and interoperability between the HISPs. Ask your HISP provider to show you the grid. Are they green across the board, or do they have yellows or reds that say that no, they weren't able to communicate with another HISP? Do they integrate into your EHR? A number of EHRs have multiple options. Epic and Meditech, for example, have a number of options. And what other services do they offer to help you achieve your community connectivity goals? When I'm thinking about community connectivity and I'm speaking with my hospital partners, I don't just want to know how they're going to meet meaningful use 2 numbers. I'm interested in finding out what is their goal in terms of reaching their community. How do they plan to become the sticky referral partner with each of the members of their community? With that, I know that there's a lot of questions out there, so some of my information, feel free to reach out to me. I'm now going to pass it over to Mr. HIStalk and let him moderate our fabulous panel.
Thank you, Andy. As Bill, all of our panelists today have a lot of experience with meaningful use stage 2 attestation, so we're happy to have all of you with us today and that you're willing to share your experiences in implementing direct secure messaging. For the audience, all of our panelists have Meditech experience, but you'll find that what they're going to speak about is not Meditech specific. It will translate to whatever EHR environment you have. Let's start with Ann from Union Hospital. And first, maybe Ann, you could just tell us a little bit about your hospital and what your status is with Meaningful.
Sure, Mr. HIS. Thank you very much, and hello, everybody. Union Hospital is a 122 licensed bed hospital, community hospital in Elkton, Maryland. From a meaningful use perspective, we successfully attested to stage 1 meaningful use, both the 90 days as well as the annual first year attestation last year. We're in the midst of collecting data that will add to our 90-day attestation for stage 2 meaningful use. We have a number of community providers, some hospital-owned practices and some just regular community providers who have also successfully attested to stage 1 meaningful use, and they're currently actively looking at attestation for stage 2 meaningful use.
And when you were planning your meaningful use process, at some point you determined that you needed a HISP to provide that direct secure messaging service that was integrated with your EHR team approach, getting that need filled, and then what do you wish you'd known then that you know now about that process?
Well, the first thing I wish that Andy had done his presentation for me before we jumped into the HISP world and trying to understand what it was. So the first thing we did is again, trying to understand what the requirements really meant from a secure direct messaging. And as Andy pointed out in this presentation, there's lots of confusion in my organization and even from my most savvy tech guys that they were confused. You know, is it encrypted email? Is it a special email? Just kind of exactly what was the HISP. So we had to, again, rely upon resources and reference to understand a little bit more about what direct messaging was all about. And then again, you mentioned we are a Meditech hospital, so I went to our Meditech's website to find out, if they had a preferred vendor list in terms of working with HISP. Because unlike a number of the other EHRs out there, Meditech is HISP agnostic, meaning that they don't embed a HISP directly into their EHR. Allscripts, for example, does. So we needed to identify a vendor to work with, and DataMotion was one of the vendors that Meditech had worked with, so reached out to DataMotion to get things started. But again, I think the most challenging part for us was just understanding the whole concept of direct messaging and what a HISP was and how it differed from the other messaging modalities that were available to us.
We'll say hello now to Matt. And Matt, could you give us a little bit about Steward Healthcare and what's going on with meaningful use at your place?
Sure. Yes, so Steward Healthcare is an accountable care organization, or ACO as many probably know it. And we have 9 acute hospital facilities that are on the Meditech 6.0 platform, 1 long-term care facility on Meditech 5.6. And then we also have an ambulatory network that's part of our ACO, which is a combination of Athena and ECW EHRs. And when it comes to meaningful use, I've talked more to the hospital side. We have, all 9 facilities have attested to stage 1, and at this point, 6 of our 9 facilities have attested to stage 2 meaningful use, and the other 3 are planning to attest before the end of this year.
And maybe, Matt, you could describe for us, once you selected the HISP, how you managed its implementation, what came up that was an unexpected hurdle, or what insights did you gain along the way that allowed you to get it up and running?
Sure. So in order to make this happen, we kind of had to get a team of different analysts, specialists from the different environments. So we had to get our technical network team involved, and what they would do is help to create their certificates in a format called a PFX file based on whatever servers we were going to use to communicate between our EHR and the DataMotion HISP. And then the network team also had to work on setting up the firewall permissions to allow communications from within the Steward network directly to the DataMotion network to make sure that it's secure and only those 2 servers can communicate with one another. We also had to work with our application teams for the Meditech software and set up, a number of parameters and design the system to actually work with direct messaging. One of the biggest components for that was actually just setting up our system to create what's called a transition of care CCDA, which is basically the document architecture. It's an XML document that's used to send the patient summary out. And that really took probably the most amount of time, but it really was just like mapping entries to meet whatever that CDA document required. And then the last part that we had to work with our vendor team, we actually scheduled weekly meetings between our team and the vendors, Meditech and DataMotion, and just to make sure that all the parameters were set up on time and communicate what servers we were going to be using in the Steward network and what servers we had to connect with DataMotion, and basically set up the certificates, exchange information back and forth. And it was really, the biggest hurdle was communicating back and forth when these processes were being done. So having that weekly call really made that a possibility. And some of the hurdles that we ran into while doing this, when we first started trying to set this stuff up, we were installing the wrong certificate types on our server, and Meditech helped us determine that we had to create what's called that PFX file. And then we also had firewall issues. The DataMotion environment had a testing and live environment. And in order to troubleshoot the stuff and actually find out when it was going wrong, Meditech installed a tool called Wireshark, which basically allowed them to look at the pipe, see if we weren't exchanging the right certificates for the secure handshake, or if we were calling the wrong IP or port. That was unexpected. And using that tool allowed us to troubleshoot that. And the last thing that we had to do was make sure that the document patient summary that we were sending out through the DataMotion HISP was CDA compliant. And we used what was called the NIST testing tools, which is a website where you can basically just take a test patient summary and run it through there, and it just validates that all the fields and patient information on the document is set up correctly. And really, working with the two vendors, once it was all said and done, it was really a pretty easy process in the end for us once we had that clinical document set up correctly. The vendors really helped us a lot.
Thank you, Matt. I'll remind our attendees that we'll be taking your questions at the end, so if you use the questions panel of GoToWebinar, we'll get to your questions shortly. To meet the Meaningful Use 2 transition of care requirements, the hospitals have to share the CCDA documents at 10% level or above, and I'd like to ask Anne about what did you discover when you started approaching that part of the process?
Sure, that's a great question. So that took some analysis on our part, because again, if you take a look at 10%, that sounds like a small number to have to meet, but when you start to do it, it really isn't. So basically, what we took a look at is from a provider perspective, who were those providers that, well, upon discharge, patients went back to see? What were those extended care facilities that the patients were transferred to upon discharge? And then based upon that, we went to the individual providers to see what kind of EMR they had, and were their direct trust email addresses already set up with those particular vendors. So for that particular part, Meditech has a discharge routine, and as part of the discharge routine, there's a section that says, transferred back to or to be followed up by. And and one of those providers, putting those providers' names in there, and then having in Meditech that provider's direct email address automatically on discharge, what happens is that CCDA, the patient health summary, is automatically sent to those providers. So we identified those providers. We made sure that in Meditech they had a corresponding direct email address set up, so that as part of the discharge routine in Meditech, those CCDA documents were sent to the provider. So that's what we did from the provider community perspective. For the extended care facility perspective, we work very, very closely with 3 extended care facilities in our community. And what we did for them is we set up, using our domain, a direct trust email address for those 3 facilities. And what my release of medical information staff then does is daily they go through all of our discharges, and they identify which, if a patient was discharged to an extended care facility, which one it was, and then using the direct message processing routine in Meditech, they send that patient health summary to those 3, whatever appropriate extended care facility it is. So I can knock on wood, I can confidently say that we are going to meet our 10%. Using that analysis, again, taking a look at your community and kind of your referral patterns and where your patients go after discharge. But that was an exercise that we did in advance, which really helped us moving forward.
We'll follow up on that with a question for Andy from DataMotion. As a HISP, you've helped hospitals getting their with provider community readiness. What experiences have you had there?
Thanks so much. The question really calls into mind how we meet the community need. And talking to our hospitals, we recognize two components. One is that we have to do the enablement, and the enablement with Meditech or Epic is something like using an XDR connection and the functionality there with other EHRs we're embedded in. But we also have seen the need to deploy a community web portal, a community solution portal that allows providers in the community that don't have the enabled EHR the ability to receive direct secure messages. And that's an offering that was pretty much demanded by a number of our customers because they were finding the inability to reach out to the community.
I'll ask a question now for Darby from Steward Healthcare. Can you tell us a little bit? Matt shared some of the technical details about what the journey has been. Can you talk a little bit more from your perspective, what has happened and how it's gone?
Sure, I'd be glad to share a little bit more information. For us, the journey really started with clear plans around the specific meaningful use measures that we were trying to pursue. In the introduction, Andy highlighted that direct messaging intersects with three key measures: the transitions of care requirement, view, download, and transmit, and syndromic data submissions. It was really important to identify that for us and probably for many organizations, you may have several vendor partners involved, and that you really need to be thoughtful about the information that you're going to be receiving from those vendors and how it aligns with achieving those specific meaningful use measures. It's also likely the very early experience for many healthcare organizations in terms of engaging patients in their use of technology. And I would just encourage organizations not to underestimate the challenges there. They're good ones. I think that's what meaningful use is about. But it is a challenge, and organizations need to rise to that challenge. I think I'd also highlight the governance journey that we went through in terms of supporting the process from a financial perspective, from a decision-making perspective as well. It was very important that our Chief Medical Officer, our Vice President for Medical Affairs were involved. Likely those roles would be really important to others in the audience, and then others. Obviously, there are very, very many critical roles. And then lastly, I think I'd share the classic IT lesson, just to be sure to focus sufficiently on changes to workflow and process. We've talked a lot about the technology, but that's not always the biggest challenge. It's the changes to your current staff's workflow or process. So be sure to pay sufficient attention to that.
I'm going to go to a question now that I think will have a lot of interest. We are getting, by the way, some really good audience questions, and we'll get to those very shortly. The all-important reporting to CMS, once you've got all the technicality out of the way and done your job, now you have to report to CMS. Obviously, that can be a challenge. I'd like to start with Darby to tell us about any experiences or recommendations you might have based on that part of the project.
Yes, it is an important area of concern and focus. We started by critiquing the tools that our respective vendor partners provide, and just know that some troubleshooting of those existing tools and or refinement or adjustments to the configuration may be required. Many of these reporting elements are dependent upon settings in your respective EHRs or in your HISP or a DataMotion type partner. And just plan for a settling out period. Don't expect to just turn on the reporting and have it work. Sort of anticipate that settling out period. We also experienced additional analytics that really helped us be successful. And so what I mean by that is taking some of the data points that our vendors provide and providing additional visualizations of that data or different analytical views. So things like being able to trend our progress over time, possibly showing the delta to the target and calling that out for maybe an eligible provider that's struggling getting to their target. And then breakdowns by market, not just by the hospital or an eligible provider. Ann also brought up a really good point in terms of maybe some additional analytics. So, for example, when you're thinking of your transitions of care targets, make sure that you have some tools that help you focus on the providers that are going to represent sufficient volume for you to get to your target. So, again, use the tools that your vendor partners have, but then also anticipate some additional analytics that you're going to want to do to make sure that you can monitor your progress towards your goals.
Do any of our other panelists have anything they would like to add to what Darby said?
This is Bill Wynn. I would like to add that HIEs in some states and regions are starting to provide directory assistance and forwarding services. And as far as reporting, if you utilize an HIE, you should verify early on that when the HIE forwards your summary of care on, that you have a means of receiving a delivery receipt or an indication from the HIE that has been sent on. Not every HIE is going to be automatically sending a delivery receipt back to the originating EHR. And if they don't do that, then your numerator count could remain at 0. Just a little side note.
Thanks, Bill, and we'll stick with you for the next question as well, since you have experience out there in the field with folks that are going through this process and what their key success factors are. What would you say is most important for those hospital clients who are trying to integrate direct secure messaging in their EHR as they're pursuing stage 2?
I can think of several items that really come to mind. Probably the easiest is to get an early start. Your hospital and clinic has to go through its normal acquisition and contracting process with the direct and the HIS vendor. And for a larger system, sometimes that can take quite a bit of time. You're going to need to agree on a business associates agreement. That'll have to be signed before you start sending patient data over this. I think Ann referred to this, being able to create that consolidated continuity of care document, the CCD, internally, and assuring that all of the fields are contained in it and information that should be populating it really is. That's something you need to be doing in parallel to acquisition. And I think Darby referenced the fact that installation and configuration takes time. It's a three-party endeavor. You have the facility, your direct and HIS vendor, as well as your EHR vendor. We're starting to see that there's people are getting back. There's some backload here, and a lot of facilities are saying, "Ooh, I need to have this in place by October," and so they're trying to schedule time with the EHR vendor and the direct and HIS providers, and schedules are filling quickly. I think the second thing everyone should be aware of is that there is no directory of direct addresses. And right now, most hospitals and clinics are having to go out and gather those direct addresses from other facilities and clinics and primary care physicians. That takes time, and you need to really assign a staff member or two to work on that. It's not something that you do in your 10-minute break in the afternoon. The reference to analytics is real important. Take a look at the facilities, hospitals, nursing homes, hospice, SNFs. Look at the ones where the majority of your patients are transferred and contact them first to set up, to obtain direct addresses from them and let them know that you're going to be sending. It always helps to be able to tell them that Oh, and by the way, our direct address is. Most of these facilities are trying to meet meaningful use also. You can contact your area clinics and individual PCPs directly to get direct addresses. There are some facilities that are providing direct addresses for local PCPs or clinics that have not obtained them. You need to keep in mind that you don't violate Stark laws, but look at the passing on the costs to the clinic or the PCP as a means of having a recipient for that summary of care. You really should go out and test the processes you're going to use to perform these transmissions. The reference to staffing is really important. Most facilities end up looking at this as a release of information, and because of that, the responsibility falls to the HIM department. That'll be for transmission as well as receiving incoming CCDs. So it's a new responsibility for HIM, and staffing considerations will need to be made. It's ongoing, it's 365 days, and it will pretty well be not a one-time shot. It's a responsibility and set of duties that will be continuous. Last, I would say start sending. That 10% minimum 2015 will be over a 365-day period. But if you wait, say 6 months, before you actively start sending CCDs out, that 10% becomes 20% that you have to achieve in those final 6 months. And you're going to start running into problems hitting those numbers if you delay. I think that's pretty much what we've seen in the area so far.
All right, very good. Thanks, Bill. We'll go to our audience questions, and we have some really good ones. So here's the first one, and that ties to what Bill just said. What process change occurred in your hospital to generate the summary of care target at 50%, not so much the electronic target of 10%? And I guess maybe we can start with Ann on that question.
Sure, that's a great question. So again, it's all about looking at the process, looking at the workflow. So what we did, again, is use the discharge routine, identify actually what we needed to send or to print out, if you will, in the discharge packet. So when we created the patient health summary, we looked at, make sure we had all the key elements that were there. And as part of the discharge packet printing upon discharge, and that's where the 50% comes through, we include the patient health summary as part of that. But what we did in preparation for that, because again, that's, it's a change. What are we actually giving the patient to take home with them? That's different. So we actually created a kind of a cover letter to the patients that said, you are receiving this information as part of, gaining information about your healthcare stay. Please make sure that you send this information or that you share this information with your primary care provider, with the physicians that you see in the past. And then we kind of packaged it all up in a nice envelope, and upon discharge, the nursing staff or the unit clerk would actually hand that to the patients.
Darby, do you have anything to add to that?
Sure. I would second Ann's comments about effectively communicating those changes. I think that's right on target. Maybe one additional point to make is that you'll likely experience different idiosyncrasies by EHR. So just because you've been successful with one of your particular EHR platforms, don't assume it's going to work exactly the same way for the others, and so consider that in your planning and work very carefully with each of the EHRs. Ann described a very clear set of steps that applied in that particular case. Just know that that's likely to vary by EHR, and you want to get ahead of it. Pretty much to Bill's comment about planning ahead, build in enough time so that you can have those conversations, understand how your respective EHRs work with respect to this particular measure, and then execute accordingly.
We have a question from Ryan in the audience. Appreciate that. This one's for Matt. Ryan would like to know the name of the website that you referenced to test the CCD document.
It is the NIST testing tools website, and they have a link in there. And maybe we can send this out afterwards to the participants, but there's a link in there to actually look for the transition of care specific CDA document, or if you're doing if you download and transmit for your patients, you can test either one of those documents directly. You really just upload it onto the website, and then it validates it for you. But it's NIST testing tools, NIST.
Thanks, Matt. Here's a timely question. I'm not sure who the best person to answer it will be, but the question is, can someone speak to the impact of direct to hospitals based on the changes published by CMS on Friday?
So this is Ann. I mean, I'll see if I can tackle that one. So I think the changes that CMS came out with on Friday talk a little bit about the certification of your EMR. So if you're, I know a number of vendors had challenges in terms of getting their EMR or certified to 2014 editions of the requirements. So I believe the 2011, the CMS allows the hospitals to kind of attest to 2011 standards. The actual direct email transmission of patient health summaries is not included, again, to the best of my knowledge, not included in that 2011 requirement. So in my estimation, you wouldn't have to meet those particular standards. That's my understanding, my interpretation. And maybe Bill knows better than I do.
I'm not sure I know better, but to elaborate a little bit on that, if you read through the final rule, if you really had nothing better to do over the last 4 days, the phrase unable to fully implement a 2014 edition because of issues related to availability comes out again and again in there. So if you can prove that you were not able to obtain and install a 2014 certified edition, then you could qualify for that exemption and drop back to stage 1 requirements. If you had it available, I mean, let's say you installed your 2014 edition in January, you're not going to qualify for an exemption. There is one, what I think, major exception to that, and it is related to direct. CMS went in and said, we understand you might have a 2014 edition, certified edition installed, but the people and facilities to which you would be sending a direct message might not. So if the recipients of the transition of care document are not at 2014, then you could apply and qualify for an exemption and be able to drop back to stage 1 requirements, even though you're scheduled to do stage 2. So they're not really giving, the read on it is if the people receiving the CCD are not able to do so because they don't have a 2014 edition, then the sending hospital or clinic could avail themselves of the exemption. I would suggest if you do that, you really document your logic and your reason and your situation for an audit. I don't know if that answered the question or not.
Yeah, I think, Bill, this is Annie. I think it's, again, my read on it is they're going to make it, it's going to be challenging to really go for that exemption to all the points that you've just articulated. So, again, document, and have like a really definitive reason why you're asking for it and be able to demonstrate very clearly why you think you qualify for it.
Thanks. We have a attendee who has a clarification for Ann's comments about the certification. And Allison has to say that if you do not have a 2014 system, you have the option to use the original Stage 1 2013 measures, regardless of the stage you should be attesting. You can also use 2013 CQM, so I'll just throw that out there in case anybody was questioning. A lot of people are interested in what's going on out there with the changes. Let's see, here's another question. This one's an interesting one. This one may be a Bill question, but I'm not sure. From Scott, if you send to yourself, so to speak, when setting up direct mailboxes for other facilities on your own HISP and direct domain, does that count towards your MU2 goal?
This is Bill. I think the way CMS has stated it over the past couple of months is that if your standard operating procedure is to always send electronically your CCD for all of your discharge patients, regardless of whether or not the receiving physician or clinic has access back into your EHR or not. If you do that as a matter of course, everybody gets an electronic CCD. If you can come up with a direct address, then those would qualify. Now you can't send it just within the Meditech system. You couldn't send to an internal Meditech direct address. In other words, you couldn't send to, Darby could not send it to himself and have that count. But if Darby was a practicing physician out at a clinic, in addition to being on staff at the hospital, and you did that for everybody, then it should count.
Yeah, Bill, I agree. This is Matt. I agree too. There's actually an FAQ on the CMS website specifically addressing that, and the interpretation was that if it was, as long as it wasn't going intra EHR within the same EHR, that it does count towards your TOC count.
And again, this is Ann. Just another little comment to kind of add to it again, and something we stumbled upon, and we just had to kind of make sure we're meeting the requirement. It's unique patients too. So for example, in the routines I described in terms of sending upon discharge, there might be 3 different providers in that discharge routine, and each of those providers would get a copy of the patient's CCD. However, that patient, you can't count that 3 times. You can only count it once. So just to kind of make sure that whatever reports and data that you're collecting, that numerator doesn't reflect unique patients.
Thanks, Ann. Here's a question. What does the panel see as the proof that the TOC document sent via direct was received? What do you see as needing to have for future audits?
This is Andy. I'll start with that from a technical perspective, and then I'll let the hospital specialists chime in. From the letter of the rule and the direct protocol as it's written, the message disposition notification, or the response that the message was received by the receiving HISP, meets the standard under the direct protocol and the direct standard. Whether or not the individual EHR processes that MDN internally is somewhat different. So that is a great question to be asking your EHR provider. Do they track that? And also your HISP provider, how do you check the MDN, or message disposition notification, to see the status of the message?
Yeah, I can talk about that from our perspective that we worked in with Meditech and DataMotion. So what we had to do is every time Meditech sent out the transition of care, it stored something against the patient saying it was sent out and whether it was successful in sending out to DataMotion. And I just had to reconcile that to the receipt that was available in a DataMotion, what's called total view report. And once I was able to reconcile that, that was a confirmation that the message was not only sent out of Meditech, but also made it to its final destination. So you have to kind of reconcile those 2 different reports between the different vendors.
Yeah, and this is Ann. That's exactly the same thing that we're doing, and we're making a point from an audit perspective, making sure that we describe that in our methodology.
Thanks, everybody. Here's a question from Nancy. The question, this might be I'm not sure if it's an Ann question or an Andy question. Do you exclude those discharged to home from your transition of care measures? If not, why not?
We don't, and again, I know this is kind of a controversy. Some of my colleagues are indeed excluding them, and the reason we chose not to is because our interpretation is that it's a transition of care from hospital back to the primary care physician or the family doctor. So in our mind, that discharge to that particular patient represents a transition of care. So we do include patients discharged to home.
This is Bill. From the CMS regulatory point of view, you do not need to include discharges to home in your denominator. I understand exactly why Ann is including them, and a lot of facilities go ahead and do include all discharges, whether they're from the ED or inpatient, in their denominator. The CMS does allow you to exclude discharges to home from both inpatient and ED.
I have a regulatory type question. Do you have concerns about anti-kickback by providing post-acutes direct mailboxes on your domain?
And again, that's a great question. We don't, I guess, because of the collaborative relationship we have with 3 different organizations in our community. I would have concerns if I only picked one. But again, we're doing this as an equal opportunity to all of the extended care facilities in our community.
This is Andy. So one of the other components of that that Data Motion recognizes is that when you're providing a direct secure messaging address to someone in the community, if you inform the provider that they can use this with any other direct secure messaging, so that you can send and receive not just from the hospital but from other providers, so that they can use it more generically and it's not specific to the hospital, it becomes just a community tool and not dependent exclusively on the relationship with the hospital.
Here's another question, more of a future type question. Given that meaningful use targets allow generic secure email to communicate with patients, do you think there's an incentive for patients ultimately to have direct message addresses, and do you foresee later stages requiring this?
That's a great question. This is Andy again. The first challenge with the patients having their own addresses is that the Direct Trust and the accredited HISps have an expectation that when the identity is validated for anyone who has a direct secure messaging address, that it's been validated at what we call level of assurance 3, or LOA 3. That means that we validate it against 2 separate identity components, whether it be a financial and a government-issued ID or something like that. Most patients are not willing to go through that kind of identity validation process. Secondly, the cost of that certificate and the cost of that feature is not very high on the general consumer's list of expenditures. So patients thus far, if you think about HIStalk, Microsoft HealthVault coming into play about 5 years ago, and the fact that it still has a very, very low penetration rate, even though it was free, PHRs still aren't there yet. Now, having said all of that, I think we're seeing more and more health systems and more payers saying, patient, the more you take care of yourself, the more you become responsible for your own care, the less you're going to pay. I think the future may hold that, but it's going to be very hard for CMS to say you have to drive more patient engagement when the patients are truly not engaging on their own.
And this is Ann again. I mean, I agree with Andy, and I think again, there was very, very high hopes for patient engagement using the portals, and patients were going to jump at the chance to get information about themselves. And again, I know I'm not alone in terms of our organization's experience in trying to get the patient to either sign up on the portal, try to make that to meet that requirement. And until there's that cultural shift, until there is incentives, whether they be less of an insurance payment, et cetera, it's going to be hard to get patients to actually to even have their own direct trust email address. So I don't see it coming unless things drastically change in terms of incentivizing folks.
question from William, who would like to know, for the menu objective for electronic lab orders to ambulatory provider, how can a hospital leverage direct?
This is Bill. I can speak from Meditech. They are currently, I don't think it's widely available yet, but using the Massachusetts State HIE, the Mass Highway, they've implemented a hardware solution that allows HL7 messages to be converted to a direct message. And they're looking at that as a possible solution for ambulatory providers to send out their request to the lab, as well as the lab providing those results back to the provider, which would meet that ambulatory lab result menu item. Meditech's also looking at a software natively being able to send and accept lab results via direct. Right now, they are only able to attach a CCD to their direct message. But I think we'll start to see really a much increased use of direct over the next couple of years, not just to meet meaningful use requirements, but as a means of secure messaging between healthcare entities.
This is Andy. I'll echo that. From a technical perspective, direct is very, very similar to email in terms of its functionality. The message structure has the same functionality. You have the to, the from, the subject line, the message body, as well as the ability to send attachments. So from a technical perspective, direct can support the functionality you're speaking of. The challenge comes into the individual EHRs enabling that particular technology to deliver wherever they want to deliver it to. So while the Meaningful Use 2 standard is transitions of care, view, download, transmit, very, very specific, and so the enablement has been very, very specific. Long term, I see that opening up and becoming a more standardized communication tool.
Finish up with Andy, if you could just, we've talked a lot about in generalities, but maybe as our host today from DataMotion, if you could just spend 60 seconds to tell us what DataMotion's capabilities are to cover the things that we've talked about.
Absolutely. DataMotion is a secure messaging provider. We have been in the business of providing secure messaging and meeting regulatory compliance for more than 15 years. As a direct secure messaging provider, we have gone to great lengths to not only be a fully interoperable HISP and having the ability to reach out to every other HISP. We have a community web portal which allows providers in the community access to direct secure messaging when their EHR does not meet the needs there. We also have the ability to consult with you on how to meet your needs. One of the things that I recently consulted on a number of hospitals with is during your discharge planning, is the discharge nurse or the discharge coordinator sharing the patient portal with the patient, showing them how to log on prior to them departing the hospital so that they not only have they logged on, but they actually have their user ID and password written down so when they go home they can do that. And these are just little tips and tricks to help ensure the hospital success, not just at Meaningful Use, but at being a great community resource.
Thanks, Andy. With that, we'll conclude our webinar. I want to thank all the...
I'd like to thank our panel and certainly our attendees. No, go ahead, Laura. I was just going to wrap up and thank our panelists and throw it back to you.
Well, that's what I was doing too, and I muted you, and it didn't work. You unmuted yourself. And I want to thank everyone for attending today, and thank DataMotion for putting this webinar on. All the panelists and Mr. H for the informative and entertaining discussion. And as a reminder to the attendees, watch your email for links to the recording of today's webinar as well as a PDF version